Hello, my name is Yoshiko Takei from Japan. And Debbie has just explained about perceptual assessment in the previous section. Now I will talk about supplemental approaches for detecting nasal emission and hypernasality. Mirror test is used to determine the presence of nasal emission. A mirror is held under the nose during speech, and if the mirror clogs up with condensation, it indicates nasal emission. The timing of the placement of mirror should be considered because usually there are more fogging at the beginning and at the end of the speech. At the beginning of the speech, you might pick up normal nasal breathing, and at the end of the speech, the velum lowers and air comes out through the nose. Inaudible nasal emission may be detected by the mirror test. If there is no other evidence of BPD, such as hypernasality or weak consonants, no further treatment is required. But it is worth monitoring the patient just in case. Another useful approach is nose holding test. It can be used to detect hypernasality and nasal air emission. When you're assessing hypernasal speech, ask the patient to produce vowels or low-pressure oral sounds with the nose unoccluded, and then repeat the same sounds with the nose occluded. If there is no change in resonance, this means the patient probably has normal velopharyngeal function. However, if the resonance changes when the nose is occluded, then hypernasality is indicated. I will show you a video of me demonstrating hypernasal speech and changing resonance when my nose is occluded. To assess nasal air emission, the patient is asked to produce syllables or sentences loaded with high-pressure sounds. If there is increase in oral pressure with closure of the nose, presence of nasal air emission is suggested. I'll show you a demonstration video here. Another situation where the nose holding test can be very useful is when distinguishing between passive and active nasal fricatives. Passive nasal fricatives is structurally related, the articulation is normal, and as the red circle in the picture shows, the tip of the tongue is not falling in contact with the alveolar ridge, meaning that the air comes out orally when the nose is occluded. Let's look at the demonstration video of passive nasal S sound. Listen to how the sound becomes clearer with nasal occlusion. On the other hand, active nasal fricative is a result of mislearning and it's phoneme specific and articulation is altered. Here, the tip of the tongue touches the alveolar ridge, stopping the oral airflow, so the sound is blocked totally when the nose is occluded. I will show you the video here. Some more explanation on active nasal fricative. It may occur in children with repaired cleft or children without cleft or BPD. Children often have a history of middle ear disease. Fricatives and or affricates are usually affected. When assessing, children produces plosives fine, and they do not show hypernasal speech. It is very important to differentiate passive and active nasal fricatives because active nasal fricatives are treated by speech therapy, and the surgery is not the option for treatment. In relation to active nasal fricative, in Japanese, we have vowel-specific active nasal error, vowels I and U, and syllables followed by I and U are often affected. For example, ki will sound like k, k, and the children with these errors are often misdiagnosed as having hypernasality. The error might be similar to syllabic nasal in English. Perceptual assessment tells you a lot about the child's speech. We now look into their oral cavity with these tools to see the structural problems, which could be related to their speech problems. What to look for? Are there any clues to poor muscle movement? Or signs of submucous cleft palate? Is there fistula? Or large tonsils? Any findings of previous surgery? Is palate length sufficient? Any problems with dentition and occlusion? Important thing to remember is that BP closure takes place in the nasopharynx, which is out of the line of intraoral view. An accurate diagnosis of BP closure for speech requires imaging studies, which we will discuss later. Dentition. Cleft patients often show dental anomalies such as missing teeth, rotated teeth, malaligned teeth, supernumerary teeth, or protruding premaxilla. Impact on articulation. You should observe tongue position and movement during speech, and determine if the distortions are due to structure or simply misarticulation. Problems with occlusion are common in cleft patients. When class 2 malocclusion is severe, patients will have difficulties with lip closure, and that causes lack of bilabial closure during bilabial sounds. In the patients with class 3 malocclusion, the tongue is often in anterior position relative to the alveolar ridge, causing difficulty in producing alveolar sounds. Also, F and V sounds may be affected and produced as reverse labial dentals. And in the patients with anterior open bite, interdentalization is a common error. Again, I want to point out here that having malocclusions, like the dental anomalies, does not necessarily cause articulation problems, so it is important to determine whether the articulation problem is due to the structure or whether it can be improved by speech therapy. Move on to oral nasal fistula. When you are doing oral examination, always look for fistulae and check their size and location. The effect of fistula on speech depends on its size and location. A small fistula is usually not symptomatic. A medium-sized fistula can cause consistent nasal air emission, particularly anterior sounds. A very large fistula causes hypernasality and nasal air emission. There may be consonant distortion in patients with fistula, and it is reported that anterior consonants are more affected than posterior consonants. The patient might try to avoid the fistula and produce the sound behind the fistula, or the patient might try to close the fistula with the tongue, which can cause a lateral distortion. And also, large fistulae can cause regurgitation of food and liquids into the nasal cavity during eating. It is important to determine the cause of nasal emission and hypernasality. Try to compare the occurrence of nasal emission on anterior sounds, such as P and T, and posterior sounds such as K. If there is more nasal emission on anterior sounds, fistula could be the source of nasal emission. And if there is no difference among sounds, velopharyngeal valve could be the source. Temporal obturation of fistula can be helpful to determine the cause. Materials such as chewing gum or gutta perca, which is used in root canal treatment, or some other adhesive materials is used. If the nasal emission is diminished, fistula could be the source. And if there is no difference in nasal emission, velopharyngeal valve could be the source. I never do this technique myself, and I recommend to get help from a dentist or surgeon. Determining the cause of nasal emission could be very complicating, and it often takes a multidisciplinary approach to formulate the appropriate treatment plan. So reference to Cleft Palate team or instrumental assessment is recommended. Submucous cleft palate can be identified through an intraoral examination. The signs of submucous cleft include a bifid uvula, translucent blue area which is called zona pellucida, a notch at the junction of hard and soft palate which could be found by palpation of the palate, and incorrect muscle alignment which can be easily seen with phonation. Additional factors on submucous cleft: the patient might have short palate or show poor velar elevation. Some of them can be diagnosed during intraoral examination, but often found or confirmed on nasal endoscopy. It is always useful to check the history of the child, including whether there have been history of conducting hearing loss or episodes of nasal regurgitation, particularly in the first year of life. When you're performing perceptual evaluation and oral examination, carefully look for these red flags for poor velopharyngeal function. Does the patient show hypernasal resonance or nasal emission and/or turbulence? Passive, posterior and/or non-oral cleft speech characteristics? Does the patient show or have shown nasal regurgitation? Does the patient have a fistula at the junction of the hard and soft palate or in the soft palate? If you find these red flags, that's the time you need to refer your patient to the cleft team for further investigation. These are some of the instrumental examinations to investigate VP closure. Instrumental examination is used to confirm the red flags we found through perceptual assessment and oral examination, and to help determine the best treatment option. Depending on type of facility or the country you live, not all therapists have access to these specialized instruments. The best thing you can do is to try to locate a cleft team where there is a surgeon and a speech therapist working together. Nasometry measures the amount of nasal and oral acoustic energy during speech. As you can see in the picture, the sound separator plate is placed between the nose and the upper lip, and the two microphones collect the nasal and oral acoustic energy. The advantage of nasometry is that it gives an objective value called the nasal score. Score 0 means that there is very little nasal resonance, and score 100 means that there is excessive nasal resonance. The score is compared to the normative data, but the nasal values can vary considerably across different languages and regional dialects. For example, in Japanese, a cutoff score of 30 is often used. So you should be aware of normative values for the child's language or dialect when interpreting the results. Nasometry is useful for measuring changes in resonance over time, including the effects of time and growth, and changes following surgery, prosthetic intervention, and speech therapy. Here, I will show you a demonstration video of nasometry. This is the waveform when I produced a low-pressure sentence. On the left is the waveform of normal resonance. On the right is the waveform of hypernasal resonance. And you can see that the waveform on the right is shown higher on the screen, meaning the nasal score is higher.
青い家はいいよ。青い家はいいよ。青い家はいいよ。青い家はいいよ。
Nasometry is a good way to get an objective score, so it has been used a lot in research. However, nasometry does not provide any visual clues as to what is happening at the back of the throat. But in clinical practice, this is exactly what we are interested in. One of the instrumental techniques of visualizing VP closure is nasoendoscopy. In this examination, a flexible fiber optic scope is inserted through the nose into the nasal pharynx, and it allows visual observation of the structure relating to VPD as well as the function of VP mechanism during speech. The results of the endoscopic exam help us determine the cause of VPD and the appropriate recommendation for treatment. These are the endoscopic view of my velopharyngeal structures. The soft palate is at the bottom of the screen, and the posterior pharyngeal wall is at the top of the screen. And you can see the lateral pharyngeal walls here. At rest, the soft palate is lowered and the VP port is open. During speech, the soft palate is elevated, and together with the lateral and pharyngeal wall movement, the VP closure is accomplished. I'll show you a video of me demonstrating normal and hypernasal speech during endoscopic examination. You will see that in normal speech, the VP port is closed, and in hypernasal speech, the port is wide open. These pictures are endoscopic images of a patient with a short velum. There is an obvious gap during the phonation of low-pressure sounds, the vowel R and E. During the production of high-pressure sound PA, Bubbling of secretion is evident, indicating a small VP gap. Because the degree of VP closure can be inconsistent among sounds, it is better to prepare sentences loaded with high-pressure consonants, low-pressure oral consonants, and nasal consonants. Also, it is important to determine the type of speech samples needed based on the results of perceptual assessment. Another way to visualize velopharyngeal closure is to use radiographic images. Video fluoroscopy is a popular technique, which Debbie will explain in the next section, but here I will explain a little bit about the lateral cephalometric X-rays, which are still used quite frequently in Japan. Lateral ceph is a still radiographic image of the mid-sagittal plane of the head, taken with the patient's head fixed in a standardized position. This allows measurement and comparison to be made over time. Lateral ceph can be taken during the phonation of vowels or production of a prolonged S. Because it is a still image, the sounds to be tested must be continuous sounds, so the suitable speech samples may be very limited. The lateral ceph shows heart palate, velum length, velum height during phonation, and posterior pharyngeal wall, but lateral pharyngeal wall cannot be viewed. Here are the images of lateral ceph. One on the left is an image at rest. You can see the patient have short velum and an adenoid, which is indicated with red arrow. On the right are the images of patient producing the sounds. There is an obvious gap during the prolonged vowel A. During the prolonged high-pressure consonant sh, touch closure is seen. So that's the end of my talk. Now Debbie will explain about video fluoroscopy in the next section. Thank you for listening.